Dorothy Reyes, 71, retired bookkeeper from San Antonio, Texas. She rolled over in bed one Tuesday morning and the room spun. Not dizzy the way you feel standing up too fast, spinning. The ceiling moving in circles, her stomach lurching, her hands gripping the sheets like the bed itself might tip over. What nobody told her was that there's a name for exactly what happened to her. A specific, mechanical, well-understood problem. Not in her brain, not in her heart, not a sign of decline. Tiny crystals, displaced inside her inner ear. And here's the part that should genuinely surprise you. For most people with this exact problem, there's a 2-minute movement, done once, sometimes twice, that resolves it. Not manages it, resolves it. Research on the standard treatment, the kind ENTs use in office, shows somewhere between 70 and 90% of people feel better after a single session. Let that sit for a second. A problem that feels like a medical emergency, fixed in most cases with one specific, safe movement your doctor already knows how to do. And yet, almost nobody has ever heard of it. If you want health information explained the way it should be, clearly, honestly, and without anything left out, subscribe and tap like. That is how King Vital Years reaches more people who need this. Today, I am going to explain exactly what's happening inside your ear when this kind of spinning dizziness hits, show you how to tell the difference between this and something genuinely dangerous, and walk you through the simplified version of the move doctors use to fix it. Stay with me. Let's start with the name, because once you have it, you'll never forget it. It's called BPPV, benign paroxysmal positional vertigo. That's a mouthful, so let's break it into plain English. Benign means it's not dangerous or life-threatening. Paroxysmal means it comes in sudden, brief episodes. Positional means it's triggered by a specific position, rolling over, tilting your head back, looking up at a shelf. Vertigo means the spinning sensation itself. Put together, a sudden, brief spinning episode, triggered by a specific movement that isn't dangerous. That's BPPV, and it is far more common than most people realize. It's actually one of the most common causes of vertigo in adults over 60. So what's actually happening in there? Think of your inner ear like a snow globe sitting on a shelf. Inside that snow globe, tiny, crystal-like particles called otoconia, made of calcium carbonate, normally sit in a small chamber, doing their job of helping your brain sense gravity and head position. As long as they stay in that chamber, everything works the way it should. But sometimes, often for reasons that aren't fully clear, age-related changes, a minor head bump, or sometimes no clear reason at all, a few of those crystals slip out of their chamber and drift into one of the nearby fluid-filled canals that normally handle detecting rotation, not gravity. Now, when you tilt your head, rolling over in bed, looking up, bending down to tie your shoe, those loose crystals shift inside that canal like sand sliding in an hourglass. That movement sends a false signal to your brain. It thinks you're spinning, even though you're not. Your brain believes the signal, and for a few seconds to about a minute, the room appears to spin, even though you're standing perfectly still. That's the entire mechanism, not a brain problem, not a circulation problem. Loose crystals in the wrong canal sending a false signal. You can try this right now while you are watching. Not the fix yet, just a piece of self-awareness. Think back to your last dizzy spell, if you've had one. Did it happen when you moved your head a specific way, rolling over, looking up, bending down? Or did it come on regardless of position, lasting minutes or hours rather than seconds? Hold that answer in your mind. It matters more than you'd think, and I'll come back to it. Before I go any further, I need to stop and be very direct about something, because this matters more than anything else in this video. BPPV is not the only thing that causes sudden dizziness, and telling the difference isn't optional. It can be life-saving. Here is when spinning dizziness is not something to try to fix at home. Call 911 immediately if dizziness comes with any of the following: slurred speech, weakness or numbness on one side of your body or face, sudden vision loss or double vision, severe and unusual headache unlike any you've had before, difficulty walking, or a sudden loss of coordination, or confusion. Those symptoms, especially together with dizziness, can signal a stroke, and every minute matters. This is not the video for that. Call for emergency help. Now, here's how BPPV typically differs, and I want to be precise, not vague. BPPV dizziness is almost always triggered by a specific head position, rolling over, tilting your head back, bending forward. It tends to last seconds to about a minute, not hours. It usually doesn't come with slurred speech, weakness, or vision loss. And critically, it usually happens in brief, repeatable episodes tied to movement, not a constant, ongoing spinning sensation. If what you experience matches BPPV's pattern, that's genuinely reassuring information. But I want to say this clearly. This video is not a substitute for a real diagnosis. If you've had an episode like this and haven't been evaluated by a doctor, that evaluation should happen before you rely on any self-treatment, because several other conditions can mimic BPPV, and a doctor or ENT can confirm what you're actually dealing with, often with a simple in-office test. With that fully understood, let's talk about the research, because this is where BPPV becomes one of the more remarkable stories in everyday medicine. The standard treatment is called the Epley maneuver, named after Dr. John Epley, who first described it decades ago. It's sometimes called canalith repositioning, canalith referring to those displaced crystals, repositioning referring to exactly what the maneuver does. It guides the crystals back into the chamber where they belong, using gravity and a specific sequence of head movements. The research behind it is substantial. A meta-analysis pooling controlled studies found the maneuver resolved symptoms in roughly 75% of cases, about 5 times higher than the resolution rate seen with no treatment at all. A randomized controlled trial published in Frontiers in Neurology in 2023 further supported the maneuver's effectiveness as a first-line treatment. And across the broader body of research on this, most studies place single-session success somewhere between 70 and 90%, with success climbing to the 90 to 98% range when the maneuver is repeated. This isn't an alternative therapy or a home remedy in the skeptical sense. This is standard, mainstream treatment, the kind an ENT or a physical therapist trained in vestibular rehabilitation performs in office. What I'm going to show you is a simplified explanation of how it works, so you understand the mechanism and can recognize it if a doctor recommends it, or use it as a starting point for a conversation with your doctor about a full evaluation. Let me tell you about someone who went through exactly this. James Calloway, 74, retired electrician from Norfolk, Virginia. For 3 weeks, James avoided reaching for the top shelf in his garage because every time he tilted his head back, the room spun hard enough to make him grab the workbench. He assumed it was his blood pressure. He started standing up more slowly, then avoiding certain movements altogether, quietly shrinking his own daily routine around a problem he didn't understand. When he finally saw his doctor, a simple test called the Dix-Hallpike maneuver, where the doctor guides a patient's head into specific positions while watching their eyes, confirmed BPPV in his right ear within minutes. His doctor performed the Epley maneuver right there in the office. James described the spinning as gone, like someone flipped a switch, by the next morning. One follow-up session 2 weeks later, and it hadn't returned. If this explains something your own doctor never mentioned, hit like right now. It helps this reach someone else out there avoiding the top shelf in their garage. How old are you? Leave your age in the comments below. It genuinely shapes what I cover next and helps me make these videos more useful for exactly where you are. Now let's walk through the mechanism of the maneuver itself. Again, as an explanation of how it works, not a replacement for having it performed or confirmed by a professional. Think of it like tilting a marble maze puzzle, the kind with a small ball you guide through a path by tilting the board in a specific sequence. The Epley maneuver works on a similar principle, By moving your head through a precise sequence of positions, gravity gradually guides the displaced crystals back out of the canal where they're causing trouble, and back into the chamber where they settle harmlessly and stop sending false signals. The sequence generally goes like this, in simplified form. You begin sitting upright on a bed. Your head turns 45 degrees toward the affected side, the side that triggers your dizziness. Then, keeping your head turned, you lie back quickly so your head hangs slightly off the edge of the bed, and you hold that position for about 30 seconds, waiting for any spinning sensation to peak and settle. From there, your head turns 90 degrees to the opposite side, still tilted back, held again for about 30 seconds. Then your whole body rolls onto that side, head turning further so you're looking toward the floor, held for another 30 seconds. And finally, you slowly return to sitting upright. That's the general shape of it. I'm walking you through this so you understand what's actually happening and why it works. But I want to be genuinely responsible here. The exact angles, the correct side to start on, and proper execution matter, and getting them wrong can mean the maneuver doesn't work, or in rare cases, makes symptoms temporarily worse. This is exactly why the standard recommendation is to have it performed or taught, at least the first time, by a doctor, ENT, or physical therapist trained in vestibular rehabilitation, many of whom can teach you a safe home version for recurrence afterward. Here's something practical you can do right now while you're watching that doesn't require any risk. Sit comfortably and think through your last dizzy episode. Try to identify which direction you are facing or which way you rolled when it happened. That detail, left or right, is exactly the kind of information a doctor needs to identify which ear and which canal is involved, and it will make your appointment far more efficient if you bring that observation with you. I also want to mention something that surprises people. BPPV becomes noticeably more common with age, and it's estimated to affect a significant portion of older adults over their lifetime. Yet many people who experience it are never formally diagnosed. They either dismiss it as a one-off, or they're told it's just aging, without anyone identifying the actual mechanism. That gap between how common this is and how rarely it's properly explained is exactly why this video exists.
Let's talk about why this matters beyond just the dizziness itself, because there's a deeper thread here that connects to something much bigger. Undiagnosed BPPV doesn't just cause brief spinning episodes, it changes behavior. People start avoiding the movements that trigger it, tilting their head back, rolling over quickly, bending down. Over time, that avoidance can quietly shrink someone's world. Fewer trips up the step stool, more caution walking, sometimes a growing fear of falling that outlasts the dizziness itself. And falling is not a small concern for adults over 65. Balance-related falls are a leading cause of injury in this age group, and vertigo, even brief, treatable vertigo like BPPV, is a recognized contributing factor.